So, future of HPV usage as it relates to cervical cancer. So, the thought is simple. If you want to reduce cervical cancer, reduce HPV infection. You want to reduce HPV infection, reduce the number of women getting infected with it, and reduce the number of men carrying it. So, women should get the HPV shot because if they develop immunity to it, if they are exposed to human papillomavirus, they're much less likely to be infected with it. And if the men get the immunization, they're much less likely to carry it in the first place. And so you can begin to see the power then as a public health measure between the PAP catching cancer at an early stage before it's even really taken root, and then reducing infection in women and reducing men carrying the virus. Numbers are projected, at least in the United States, to drop significantly, and this could be an even greater public health success. So survival of the cancer, 5 years, is overall 66%. And if you look at it, if it's found at the local stages, it's 92%. Regional 56, distant 17. What's this telling you? The PAP catches precancerous changes. So ideally, if a woman goes in to get her PAP test done, you're not even catching local disease, you're catching precancerous way before local problems. So that would be like 99.999% survival. The point is, catch this one early. Catch it with the PAP. Catch it before it even counts as local. So why did I have you guys do this? It was long. Here's the idea. You had one cancer, breast cancer, that is very common and kills a lot of people, but it only has a high mortality rate because it is so common. We have a screening program, and it catches a lot of cases very early due to screening. And if you actually look at the 5-year survival rate, it's good. So it's more positive than I think some people think. You have one cancer, prostate, that is very common and kills a lot of people because it is common. There's not a great screening method in place, but we still catch it early because we see symptoms and it grows so slow. And so we're still able to beat it. You have ovarian cancer that isn't common, but kills at a high rate because we can't find it early and we don't have a screening program. We have testicular cancer that isn't common, but still kills at a low rate. We can't screen for it, but because of how we detect it, we can catch it early and it responds to a lot of therapy. And then we have cervical cancer that isn't common in the United States because we're catching it a lot of cases before it even counts as cancer. If we stop screening, it would be a different story, and we can get even better still because of the HPV vaccination. So, incidence and prevalence, I hope you guys learned something about that. Screening is good. Good screening isn't easy to do. You want to screen for something that's either really common or highly deadly, but you've got to have a way to treat it. And it needs to be a cost-effective way to treat. And not only that, your screening test can't be super expensive. You want your screening test to catch a lot of disease, true positives, not miss anyone that actually has the disease. So you don't want a lot of false negatives, and you don't want to worry too many people needlessly. You don't want false positives. That's a lot of worry and money. So it seems like, well, we should just screen more. It's hard to do. We can't always do the things we want to do. We'd like to screen for as many things as we possibly could. There are technical limitations. There are technology limitations. There's testing and access limitations. Once you have symptoms, it's not screening anymore. Screening means catching people before they've got a symptom. But now you can see why screening and early detection is such a big deal. You've seen the data, you've seen the hard evidence. I hope on some level this has helped. Sorry this was such a long lecture and such a tough exercise at the end of the year. Thank you for your attention and your effort. Bye, guys.